Hello, hello. Hi, everybody. This room is so full, and that's very exciting. Welcome. Can I first, before I get into things, just by show of hands, whose first time is it to matter? Anybody? Amazing. Welcome. We are so happy to have you guys. Um, Deb is popular. She's amazing. So this is going to be a great conversation. So brief introduction, my name's Rachel Lund. I am the partnerships manager here at Matter. And like I said before, I introduced both our facilitator and our guest tonight. I'm going to do just a brief introduction to Matter. So Matter is a global health tech incubator as well as a global health tech corporate innovation accelerator. And our belief is that collaboration between entrepreneurs and industry leaders is the fastest, most effective path to innovation. So we want you guys all to be very involved in this conversation, but by way of matter.socialqa.com. So please use your phones, ask as many questions as you like, upvote questions if you're interested in them, but please keep everything online versus raising your hand or interrupting or anything like that. So we're very, very excited. So now I'll get to the fun part. So I'm going to first introduce our facilitator tonight, Paige Edmison. She heads up our marketing team here at Matter and is a fabulous colleague to work with. So we're very excited to have her up on stage tonight. And then the guest of honor, who you are all here to see. We were actually introduced through way of Pangea Medical. So thank you to our lovely startup that's a part of our community for that introduction. So Deb Geihsler. So Deb has more than 25 years of healthcare experience, including being CEO of both Advocate Medical Group here in Chicago, as well as Harvard Vanguard Medical Group and Atrius Health System out of Boston, and is currently the co-founder of Activate Healthcare, which is what we're here to talk about tonight. So please give both Paige and Deb a very warm welcome.
Well, we made it on the stage without falling, which is my first concern. Thank you all so much for joining us. This is a big crowd tonight, which is awesome and terrifying for me at the same time. So first, quickly, just about Tales. I love this series because I think success often seems really inevitable when we read about it. So you hear about Steve Jobs or these famous entrepreneurs, and it sounds like there was nothing that could have happened but success. And I think that narrative actually erases a lot of the hard work and the messiness of entrepreneurship. So Tales from the Trenches is designed to get at the messiness, get at the things that don't always go smoothly in building a company and in life. And I think that's the best way to learn. So I am exceptionally grateful for this opportunity to interview an amazing leader and entrepreneur in the healthcare community. Deb has a really exciting story. She's doing amazing work. I've had a chance to hang out with her for a few hours today, so hopefully she's not tired of chatting with me. And I thought we would start, like we often start, back in the beginning. So during the formative years, and from what I understand, you grew up in Nebraska. Can you tell me about your early life?
Sure. Usually people who grow up in Nebraska don't actually live in Nebraska. But yes, I grew up in Nebraska on a farm in a very remote area of Nebraska in the corner of Kansas and Colorado. There was not a lot there. So went to a one-room country schoolhouse, did not have running water, did not have an indoor bathroom. And I went to a one-room country schoolhouse and kind of, a little bit limited education because there's not that many people that are going to come there and teach school. So you kind of just make what's due. But, it was a fun life. And I was thinking about this earlier. Sorry, I keep talking and I'll just keep going until somebody stops me. But I was thinking about this earlier. when you grow up on a farm, you actually are really a business owner. You are managing your own farm, your own life. You think about your product. You think about how much you're going to grow, what you are growing, what you're selling. You're affected by the market. You're affected by the government. You have to do planning and revenue planning. And so you actually grow up thinking about how do you make a living and how do you manage your own life. So I think it gave me a good foundation to think about, set your own pace, create your own direction, manage your own life, and do what's right. So it was, I'm very grateful for that, but I'm also very grateful for running water and being in a city. So,
So were your parents farmers?
yes.
They
yes.
were, okay.
From Kansas and from Nebraska.
From Kansas and Nebraska. Mm-hmm. And how did you eventually decide to leave Nebraska?
As fast as I could. My brother had gotten drafted, and he was told me that there was life outside the county line, and I thought, you know what, that's not a bad thing. I think there's an opportunity for me to be able to leave. Because I went to a one-room country schoolhouse, I heard the same story for 8 years, and so I had skipped a grade. I was 16 when I finished high school. My parents were sort of like, we don't know exactly what to do with you, but it'd be nice if you got a job or something. And I was thinking, I would really like to go to college and do something and create something. And they're like, no, you could be a secretary or you can be, I think, a hairdresser is what they told me. And I was like, I really am not that good at serving people. So I would really like to go to college. And they were absolutely like, you cannot go. The men go, women don't go. So I found a way to hitch a ride to D.C. and work for the FBI. And
what were you doing for the FBI? Are you allowed to tell us?
No, I'm undercover right now.
This is like a long-term undercover assignment.
We wanted to infiltrate healthcare for a very long time.
Maybe. So you hitchhiked to DC, you start working for the FBI, and you're also going to college?
Well, I hadn't really realized that there was life outside of Nebraska yet. So it was my first time to understand that there's, fast food. I hadn't been on a city bus, so I was horrified of the bus. Elevators, I used to walk 8 flights upstairs because I was like, you get on an elevator, it's a small box, where's that going to go? So it took me a while to just get used to life in general. And then when I got used to it, I thought, this is DC is probably not the best place for me to settle in and go. So I went to Michigan and started myself at Michigan State. I'm working part-time. But at that point, I really needed to work. Every dollar that I made, I had to send 50 cents home to support my family. So because the family farm at this point was not necessarily doing all that well. We'd gone from 2,500 acres down to about 1,000. It's hard to make a living. And so my job was not just taking care of me and going to school, but to try to support the family farm.
So you were working part-time, going to school at night, and sending money back to your family. Okay.
It's fun.
Yeah. I think that's a work ethic.
Yeah.
Right there.
You learn how to work hard.
So from college, did you go immediately into the world of healthcare?
No, I actually, again, the other thing was kind of isolated because I really didn't know that there were such things as professions. Like how could you make a choice? How do you go to, what do you pick in school? So I started picking things that I learned. I'd watch people do accounting. I thought I'm going to be a good accountant. That didn't really work. So that was not my lifestyle. And I thought, well, I like to talk. Maybe marketing is something that didn't work. But I just kept kind of thinking about what could I do with my career, not really knowing that I could have a career. Putting myself through school, but at the same time working really hard. So when I started at Michigan State, I kept getting promoted because I was working really hard. And so I got promoted to Detroit, and I started working for social services inner city Detroit, and I learned about the whole social welfare and that there were a lot of people who really couldn't read and write and couldn't support themselves. So it was fascinating to me. I ended up finishing at Wayne State and got a degree in industrial organizational psychology and economics, which made me kind of fit into that world of contract negotiations and labor relations. And so I convinced everybody, even though I wasn't prepared for anything, to hire me into healthcare. Like, look, I can do this. I got some advice early on in my career where how do you get ahead? when you're an outsider all the time, what you do is you sit back and listen and learn. You try to learn from people. Why are they successful? What did they do? How did I figure that out? So I asked a gentleman, I said, how do you get ahead around here? And he said, let me give you one key of advice. Be the last one to leave on Friday night. People will notice that you've got a work ethic and that you're working hard. So I made it a rule for the first 5 years of my working. I'm not leaving until everybody's gone. But I'd also come and say to people, I know I can do that. I can do that. I can do what they're doing, and I can do it. And I just worked really hard, and so I convinced people in healthcare that, look, I'm not skilled or qualified to be able to be an HR director, but I think I can do it. So they hired me. So I started my healthcare career with Trinity Health System. It was Mercy at the time in Ann Arbor.
Great. Where do you think so clearly you did not become a secretary or a hairdresser.
No.
Where do you think the vision to want to do something else and the confidence to say I can do that came from?
I think it was mostly knowing that hard work gets you results. If you take on something, you have to, I think the other thing that we've probably missed a lot over the years is you have to problem solve. If you're on the farm, you problem solve because you don't have resources, right? You just don't have anything. So you have to figure out, how am I going to make something work? And so problem solving skills are key. And so even if I didn't know anything about something, I could step back and say, don't know how to do this, but I'm going to figure it out. And those problem-solving skills helped me be able to step into and to be honest with you, I was raised as a Christian Scientist, so I didn't believe in healthcare anyway. So I was sort of like, okay, I'm going to go into healthcare, and I'm going to find all the things that are wrong with it. I realized that we're all put here for a purpose, and we all should benefit from us helping each other. And I also had that sense of community that we help each other. We do the right things. We do the right things for the right reasons, and you have good intentions, and you should get ahead.
So it sounds like your early childhood values learned from the farming community and giving back to others really informed you. But at the same time, you were quite rebellious. And,
yes, that's exactly why my parents were happy to see me go.
There you go. All right. So you are in Wisconsin.
Yes.
Working in HR. What is the path then, and what is the timeline to eventually, you were brought on to Advocate Medical Group as CEO?
So we were working at a health system in Wisconsin where it started as just a hospital, and then had the opportunity to help build a lot of the ancillary services there. We built our own residency, but long-term care, mental health, physician group practices. We grew. We started our own residency, and then we started expanding into communities. Put in the first freestanding ER. Things that were nice across Wisconsin, and then it was just, you just reach a time where an opportunity came up, and it was like, it's probably time.
Yeah.
Time to go try. And I think the basic driver for me it's fascinating to me now that I think back, but the basic driver for me was always, can I learn more and do more? If I'm already know what I'm doing now, I want to try my experience at something else. And I had never been really driven by money. In fact, when I took the Wisconsin job, I forgot to ask what I was going to be paid because I thought, well, this is interesting. And then I thought, wait, I should probably know what I'm going to get paid. And then the CEO called me in one time and he goes, we're going to promote you, and what would you like to make? And I said, well, I would like to make no more, no less than what everybody else is making at the vice president level. So it was never really I'm in it for the money. I'm in it because I've learned something, and I'm going to be able to contribute, and I'm going to be able to continue to grow myself personally.
So did you say you were involved with implementing the EHR?
No, I would never do that.
No, we're not. But when it happened, you were on the HR side.
Well, I did the employee relations. I did union negotiations.
Okay.
So, yeah.
I was just going to say that would be an interesting space to be.
It's a good space not to
how
be
happy people are implementing
maybe
early EHRs. Okay, so you moved to Chicago. Is that your first time in Chicago then?
No. Yes.
Yes, it is.
Yeah.
And you step into your first CEO role?
Right.
Okay, and it's you mentioned something to me earlier about culture in large organizations. And what was it like to step into a large group with an existing culture, and how did you figure out your place?
I think it was a tough culture because there had been a lot of turnover. Nobody had been able to capitalize on that culture there. I think when I got there, they were like, "Well, you're the 5th CEO," and I think the idea from the culture was, and you won't be here either. Let's figure out how long you're going to stick in this system, and so the determination was sort of like, well, and plus it was a turnaround, and so and I think I had talked to you earlier about. You have to test your leadership skills, and I think when you're in a turnaround, you really have to have you really have to have one person in charge. While I love servant leadership, if you're in a turnaround, you can't have a gazillion ideas going on. You have to have one. Survival. And survival has to be, let's get everything lined up, let's make sure we have all the things, and we all have to go in the direction or we all won't be here next year. So you really have to have that strong leadership. Let's turn this around, let's get it going, let's do all the right things. And there is not a lot of room for let's have a think tank and talk about where we want to go. But once you get to survival and you get to that point, you kind of then have to think about your leadership skills and go, now we're at maintenance. Can we prove that we're here for the long term? Can we sustain what we've been able to achieve? Because maintenance and sustaining is critical, right? So you have to, but not all leaders are good in turnaround, and not all leaders are good in maintenance and sustaining. So you prove the point, and then you have to be able to transition to, now we've got a solid team, we've got great things in place, we're actually able to prove that we can create the results. And you have to move, if you're in the right type of organization, you have to move from that to an innovator and a servant leader and growth and development. And so you really have to be able to take your leadership skills and go from here to there, which I think is exactly what you do in a startup.
I was going to say, between survival and problem solving, you are well equipped to jump into the startup world.
I mean, you get a few shots here and there and you still duck, but
yeah. You were saying earlier that the position of the primary care doctors in Chicago was one of your first concerns coming in as a CEO. Can you talk a bit about how you saw the differences in geography,
right.
And then what you decided to do from there?
Well, there's still, we now are a national organization, and we have, one of the things we learn is that healthcare, the systems, the processes are pretty much the same, but there's really differences in the geography. As an example, in Minnesota and Wisconsin, you see a lot of physician-driven systems. You have the Mayo driven out of there, you have Gunderson, you have Marshfield, you have Dean, you have physician-driven systems. And we actually looked at our physician group as the group, and the hospital as a cost center of the group, right? Mm-hmm. So as your CFO will always tell you, follow the money. Where you set up to make the money, that's where you look for your operations and how you guide it. And so you see it in that geography. When you get to Chicago, what you realize is that there's a lot of health systems, and the systems kind of control the marketplace. And so it was a little bit of an eye-opener for me that, we're now here with system beds and services, and it's high intensity, but primary care was not high on that priority.
And did you know that moving from Wisconsin to Chicago, or were you learning on the job?
No, well, I was still a little bit naive, you don't, as I always say, everybody always says the same things, and it's not until you get into the situation that you learn that things are really different. We all say the same things across country about healthcare, but we get into it and we say it's delivered differently, the philosophy is different, there's different things going on. And my concern in Chicago was, we have great primary care providers. We have really great primary care providers. And it's really hard to make a living in Chicago, and it's really hard to create a practice that you're actually going to be able to pay off your student loans and take care of yourself. And quite honestly, they should be the core of your you're managing your patient. And so I used to sit there and think to myself, I would like to tell them to go 2 hours north and they'll make more money, but we need them here. So I was trying to think about, how do we promote our primary care? And I think one of the lowest points in my life was when I hired an internal medicine doctor for $80,000, and I went home that night because he wasn't being able to make, his group work. And I went home that night and I thought, okay, this is really awful, and I feel really bad about that. And so yes, we did take over the practice, but that's not the right thing to do. So we need to find a better way to do things. And came back in and, we gave him a raise. but still, it was really hard. So I wanted to try to find ways where we could have the primary care providers make a living and put them back in the center. And we went down and cut an arrangement with the Police Officers Association of Chicago. And I learned a lot of lessons from that, in that if you have the right provider talking to the right group of people, you gain a lot of trust. Because most patients, and trust me, it's worse today than it's ever been about people trusting healthcare. I mean, I always say to CEOs across the country, if you think people trust healthcare, walk through the halls of a hospital and have the patients questioning you about, am I the right patient? I've not seen you before. Or, you sure you should be writing in my EMR? But it's a question of patients being able to build that trusting relationship and getting to know your patient. And once you develop that relationship, you can actually help guide and support that patient. And so we found that by bringing the providers on site, creating that access, people being listened to and being trusted, that there was a big demand there to create more access and more relationships.
And so you spend time in Chicago at Advocate, and then you're recruited to Boston.
Right.
How you could decide to leave Chicago?
I don't know.
Boston, I don't know what you were thinking there.
I will say this, Charlie Baker, who's the governor of Massachusetts, and he's a really tall guy, he's 6'6", and he used to look down at me. He went to Northwestern, and he'd look at me, and he'd hate me for saying this now, so I'm sorry. But he'd look at me and he'd go, Deb, Chicago's a better city.
Did we get that on tape?
No, sorry.
I'm just kidding.
I go, yeah, okay. But it was different. Talk about culture. When you go from, cities have cultures, organizations have cultures. You go into Massachusetts, they have a culture. Right? And history is their culture, right?
Yeah.
History, we've been like this forever. We're going to be like this. And the other thing that was interesting to me about the Massachusetts market is that most of the usually you have an integrator in the marketplace. But when you look at Massachusetts, most of their carriers are all home-based. It was Blue Cross Blue Shield of Massachusetts, you had Tufts, and you had Harvard Pilgrim. They all managed that state. So you didn't have an outsider that's carrying different ideas and thoughts across the state line. It was really kind of integrated, and it's supportive of that culture. So it was a different culture to think about.
And what kind of leadership were you stepping into there? Was that a turnaround where you're in survivor mode? Was it in sustaining? What was your task?
That was an interesting culture to step into. That one was where they just wanted me to be there. Just occupy that role.
Just like physically come in and sit in an office? And
it didn't fit with my value system too much, because my value system was I have to earn my money. And earning my money means you have to be creating new revenue and doing new sources and doing, it's just, and so I was coming up with all these ideas, and they're like, it was traumatizing a little bit. It's like, slow down, what are you doing? So it was, so I was like, but there's so much that we could do. And there's so much that we could prepare for, and we're going to get 3 more million people that are going to be covered by insurance in this plan. How do we figure that out? Let's be proactive instead of reactive. And so it was a little bit traumatizing to people.
And is this pre-2008?
Yeah.
Okay.
Yeah.
So I think you mentioned that you were part of a task force of all the different CEOs in the area.
There was 5 of us that were put together by the Blue Cross Blue Shield locally that said we want 5 CEOs to come together every month for 2 years to think about delivering healthcare in a different way. And that was New England Baptist, Beth Israel, Dartmouth, Mount Auburn, and myself. And so we got together every month and we sat down and talked about how do we do a better delivery system. So I would sit down every month and go, my idea is to never let them get to the hospital. That didn't go over well with the hospital CEOs. They're like, well, that's not working. So I said, but wouldn't that be best if we actually took better care of our patients and we actually had more time with them and we could actually do things so they actually didn't end up here? It's like, they weren't fond of that.
Was your board of directors fond of
They were still a little traumatized. So what is she doing here?
Too soon.
But so I tried to find ways to kind of let's find a medium in here. Let's talk about Mercer. Let's see if we could have our patients screened first, so that when they get in, we know who the carrier is. We're not going to see that happen. They're like, okay, that's kind of okay, but we're still not like that. And then we talked about prospective payment, and then they're looking at me like, well, if you're saving all the money, aren't you going to share with the hospitals? And I'm going, no. so, so, um, so then I thought, I'm just going to try to kind of plot my own little chart here. And then, so I wanted to see, so I wanted to promote more primary care. I wanted to say, let's pay them more. Let's give them more money. Let's put them back in the center. And so what I wanted to do was I looked at our population. I said, I just want to take a sample population and see, kind of study if we had intervened and spent more time with them, could we have reduced a lot of the downstream churn? Could we have stopped some of the extra co-pays and the time that people are spending and fixed them sooner and not necessarily had them hunt and find for what the solution is to their health care and reduce that repetitive visits. And I will tell you, I was absolutely shocked about how much, and I just looked at co-pays by individuals. Let's just start with looking at co-pays by individuals and see why they're here and what's coming, and is there a common thread. And there was one lady, and we must have really mistreated her, but in 1 year she had 98 co-pays. I said, we are so mismanaging some of our populations, and what could we have done to actually to intervene and provide better care? And so I worked up some statistics, some data, and some dollar amounts, and said, look, if we just increased our primary care providers, gave them some more money, let them have more time, we wouldn't have to try to keep feeding patients through, and this would be a great deal, and everybody would win. We'd be able to have people get better care, everybody'd be happy. And so I showed that to the Blues, and they were like, no. We're not going to do that. So I was like, it's really hard for me in my value system to go home at night and think, now that I know this, can I really live running an organization where I don't feel like we're doing the right thing for our patients? And the answer was, no, not really. And I was invited to speak at New York at Columbia University, and so to talk about healthcare and how I thought it could happen, how it should happen, and the way the model should work. And so I was invited to Columbia University and the talk, and in the audience was McKesson consultants, and they come up to me afterwards and said, we really think you should meet this guy in Indianapolis. He's the former CEO of Steak and Shake, and he's looking at it from the employer point of view of, I have 20,000 employees, and my healthcare costs keep going up. And as I look to and ask everybody questions about how are they controlling the healthcare costs, they're not. They're not in the business of controlling healthcare costs. So it looks like you actually have a model where you could actually control healthcare costs, and I would like to see if we could start Activate, and that's how Activate got started.
So that's the point where you decided to leave the health system side and jump into starting your own company.
Yes. I don't recommend that for everybody.
So what was that like? So you'd been going to a large healthcare organization every day to at least fill a seat and try and affect change. Mm-hmm. And did you work from your house? Like, what were the early days like?
A little bit shocking. First of all, I had decided to partner with somebody I'd never laid eyes on before. Or never met before. I didn't know the history. I didn't know, I didn't know anything about it. I'm like, okay, now I've got a partner who was a very dogged, determined partner. So I loved the model. And I was sort of like, okay, part of me was thinking, okay, I'm giving up a career. I know how to run health systems, but I don't necessarily know if I'm going into an industry that's going to make me lose my skill set, or I'm going to not be accepted back into being a CEO, or is this really the right thing to do? I wasn't really sure about that, but my instincts were, this is probably the right thing to do, and we should probably give it a try. And so, but as typical the way I am and my nature was, okay, if we're going to do this, I have rules, and here's the rules that I can't compromise. And I laid out the rules. Number one was we're going to hire primary care, and they're going to be on our payroll, and they're going to be hired full time. They have to have the full attention of what we're going to do. Number two is anybody can create access. You can create and set up a shingle and put up a door and create access. But that access does not prove anything, because the patient is still deciding when they want to go or when they don't want to go, and you're not getting the right people and you're not getting it at the right time. So we're going to create an opportunity when we go work directly with employers. We're going to encourage everybody to come in and get established care and get evaluated early. So we're not going to just sit and wait for them to come to the door. We're going to engage people from the very beginning. And the third thing was, we're not going to give people their health information and let them walk out the door. What happens? We tell people all day long what conditions they have and what they are and how they're labeled, but we don't tell them how to live with it. And so we're going to train our providers to be able to tell you, how did you get this condition in the first place? You know, why are you diabetic? Why? And we don't want to call them diabetics. We want to say, why do you have diabetes? You know, and so how did this happen? And how does your lifestyle contribute to your medical condition? And how can you be empowered to own your health care, to actually understand? And trust me, there's a lot of people out there who don't have control over a lot of things in their life. But when we empower them to have control over their health care, it's amazing how that spreads into their whole view of everything else. Because now they own their health, and they can do something about it. But we don't actually think about owning our health, because for years, we have had always that safety net of, there's always somebody here who's going to take care of me when I need it. And that really didn't make us any healthier. In fact, I think it didn't help us at all. So I think, actually having the patients start to think about, and as I tell the providers when we hire them, there is only one person in the exam room who can improve their health. That is the patient. If they don't understand, if they're not compliant, they don't appreciate the reasons to be compliant, we haven't gained anything. And I would see literally CEOs across the country buying the latest kiosks and this, and they were doing HRAs, and they were doing all this stuff and trying to get, and doing the wellness programs, and people were resisting. And why were they resisting? Because it felt like you're trying to change my behavior. You want to change me. You're not understanding me, but you want to change my behavior. So we wanted to go in and say, let's learn about your health. And trust me, there are a lot of reasons why people don't go to the doctor. I always say healthcare is a little bit like gyms. Those who know how to use it go first. So we try to get those people early. And why don't they go? Well, they're intimidated. I may not ask the right questions. I don't need to be told to give up the things that I like. You know, I don't want to give up smoking and drinking and eating better. Why should I pay somebody to tell me that? You know, it's hard to get into, and they don't pay attention, and they don't respect me. Well, you want to turn that around and say, you are the customer. You're here. You're why we're here. We want to learn about you. You're different from me. I'm different from you. We had too much of this. I'm old. I remember back when we had general practitioners and general surgeons. Now we have a specialist for every body part. And so we need to get back to the whole person and say, who are you, and how do we help you have a health plan and get healthier? And so that's what we tried to create.
Yeah, well, it's a really beautiful blend of respecting human agency and also walking into a space with the patient without judging them.
Right.
As we've talked about with Activate, I think I have a quote somewhere from you saying it's the first time you've seen happy patients, happy physicians, and happy payers, which in some sense sounds impossible. But for those who aren't familiar with Activate and what you actually do, can you walk us through kind of how it connects to the principles and the rules that you laid out, and what that actually looks like as a patient or physician?
Right. So the rules were that we were going to hire the providers full time. So that made it a little bit complicated, because you have to have the right size panels, and we wanted to have the employers pay us. I don't want to collect. We didn't want to do any billing. I didn't want to collect from individuals. We're going to collect from the employer. And we had determined that the employer has a large influence over somebody's lives, as well as healthcare has an influence over somebody's life. So collectively, we can actually have a good impact. So the employer pays us, and we manage the total population. So it's usually all employees and the family members who are on the insurance plan. So it's no cost for them to use the primary care. And we start the partnership early with the employer by understanding who their population is. We roughly have about 1,200 members per provider, and so we were trying to set up our clinics to have about 3,000 per clinic. And so that partnered with a physician and an advanced practice nurse practitioner or PA. So then you find companies that want to come together. So our first organization was a county government who had about 1,000 belly buttons, as we call them, and then we needed a few more to be able to fill in. So we ended up with 5 companies coming together to start the clinic. We understand our clients, and so we sat down and said, you're going to be part of the selection process of your physician team. So they actually interviewed the physician team, and they were part of that selection, because we wanted 2 things. We wanted them to say we're proud of the provider that we have at our clinic, and we wanted the provider to say, this is my population to manage. I want to come in every day and I'm going to take care of everybody here. I want to be able to really care about this population. So we do that combination, and then we try to decide what hours should we have. You know, is this a commuter population? Is this, they come to work every day at these hours, they're coming from different directions, they go home to different directions, how do we work this? So we have hours are varied across the country. We have, in our Nevada clinic, they open up at 4 a.m. on Fridays, because on Fridays, that's their busy time. So people start early. With school districts, we may be open at 6 a.m. Some it's to 7, but it's established around your population. So you create that great access, and then you sit down and you say, how do we engage the entire population? How do we reach them to think about? And this was surprising to me, that even after all these years, I've been in healthcare a very long time, there's still 20 to 30% of the population driving 80% of your costs. So 40 to 50% of the population is not engaged until they absolutely have to be engaged. They're not going. They're not thinking proactively. They're waiting for that catastrophic event or another event to flip them into that process. So we wanted to get all these people coming in early. And trust me, the people sometimes we find who are the sickest are the people who haven't seen a doctor since they were 18 and just come for their physical, and we find out, oh, we've got all these things going on. It's not just aging, you've got some problems here going on. So we really try to create that environment, and all of the costs it's all no cost. We do generic drugs, we do labs, there are pass-through costs. So all the services in the clinic are at no cost to the families and the people who are eligible. So guess what happens when you have a provider who's not worried about billing, and they look at the patient and understand their story, and they create a plan for them, and they care for them, and they appreciate their values, you actually see the healthcare costs go down. So in our very first clinic, we had the participants' healthcare spend went down 28%. And all of our customers have a return on investment, and that's with taking the cost of the operating dollars out of it. But when you think about what was back then, 10 years ago, what was happening to your populations, your employee populations, is that their premium contributions and their co-pays were going up faster than their raises. So people were actually going backwards. And so when we were helping the county governments, we were actually showing them they have money that they could contribute back into their organizations. People didn't have out-of-pocket co-pays because it was at no cost for them, because they could come. They were appreciating being healthy. They appreciated somebody thinking about proactively working with them. They appreciated being respected by a professional who would listen to their story and respect that they had a value system that we needed to understand in order to help have them have a healthy life. So it was wildly successful. As I always say, we didn't sell in California and Maryland. Our customers took us there. Our experience took us there. So it's been fabulous. It's not always fabulous. I mean, the results are fabulous.
As a marketer, I can say that's the best kind of marketing there is.
Yeah.
People are selling for you.
Yeah.
Well, and one of the things that struck me that you shared earlier was having someone listen to you not only affected health outcomes and reduced costs, but actually in some cases increased employee retention for the employers that you're working with.
Right. So in fact, that's actually a driver now for a lot of our customers. We've actually gone in the last 4 years to a lot of high copays and deductibles. And so we're now looking at how do we get people engaged earlier and how do we maintain the population. But it is a huge retention for people, for recruitment and retention. We have some fully insured companies. A lot of these are self-insured companies. But we have some fully insured who want to be competitive, and they say, I need to maintain my population. We also have the reverse of that, where people don't want to leave because they give up their primary care provider. So I had one of our county commissioners that would call me and say, I need to retire. I'm like, that's great. They go, but I can't retire because I can't have my doctor. So I said, well, okay, since you were a really good person, we'll, and it's really pretty reasonable. It's about $400 a year per person to be able to have all this care. So I said, if you write me a check, don't tell anybody about it. Don't tell anybody. For 12 months, you pay me in advance. It's going to be $985 for you and your wife. You got 12 months of service. Just don't tell anybody because I'm doing this for you. Okay, great. So then the next day I get a call from the head of chamber of that community. Can I get the same thing that he got? But no, it's a great retention process.
Wonderful. So I want to ask one question, and then we'll jump into some of the audience questions. But you'd mentioned the importance of story and how much it means for people to be listened to. And I think some of your belief in that was driven by your own experience as a patient.
Sure.
Do you mind sharing?
Yeah, no, so I find very quickly that, I'm a cancer patient, was a cancer patient. And so what I find, and in just recent experiences, is that you get labeled, so people ask you your story. Oh, I had breast cancer. Okay. Ah, okay. So what happened? It's like they automatically forgot the rest of my story. Or I love the dermatologist. So are you out in the sun? I said, well, I grew up on a farm. Oh, okay. But I'm like, I have I have more to this than just that label that I've got. There's more to me. Let's talk about it. But what I believe is the providers are extremely smart people. They already know the answers. I just would like to have them hear the story, because there's other things that go along with that. And so I think what happens is, and I learned this very quickly early on in my experience in Chicago, is that we have certain populations that we were treating, and knowing the condition underneath that helps you understand the whole person. But the person sometimes doesn't even know how they got there. They don't know why they're here. They don't know why they have that label. They know what happened to them. But you really have to piece that story together. And we have one great provider who always starts with, describe to me what you feel like when you felt your health was on top of your game. Describe to me how you feel now and what happened along the way. What are the changes that took place? What happened with you? What's your condition? I need to know your story about how did your life change? How did your health change? And how did that impact your outcome? And that does two things. One, the patient feels heard, which is great. The second thing is, if you're going to prescribe things to the patient, it's really nice to know if they're going to follow it and it fits into their value system. Is it important to me as a patient? Or maybe it's not. But it's nice to know that. And if you automatically say, hey, we have some patients who don't know they're diabetic or they're pre-diabetic, they don't want to admit to that. And so they'll say, like, I am never going to take a shot. Okay, well, how do we figure this out? Like, okay, we need to know that. Rather than just prescribe it to them and here's your medication, just go on the way. Well, I'm not ever going to take it. Okay, why? We need to understand that. So we just have to hear that person and that story and how they make decisions and why they make the decisions they do and what their value is about that. And that makes all the difference in the world about when we approach them.
And then free up the physicians to do what needs to be done to
Right.
take care of them.
Right.
Yeah.
Right.
Absolutely. That actually connects really nicely to our most upvoted question at the moment is what we're talking about right now is very relevant to patient-centered care. So the question is, how do you feel about the transfer of accountability to the patient? And how do you kind of encourage that accountability for their own health? And I'm sure that fits into their own values and systems and belief structures.
Yeah, I mean, I think as I say, that the only person who can improve their health is the patient, but we don't always give them the tools to be able to make the right choices. And plus, you can't expect the patient to change their entire lifestyle. So their lifestyle is an impact as well. The social determinants are important. What are they challenges? What are they dealing with in their lifestyle in order to help guide them through that process? So yes, I think patients are the ones that should own their health and should be accountable, but you can't do it on your own. You really have to have somebody who's guiding you and understands the health system. And I was really never for consumerism. So I really felt like I've been in healthcare for the last 30-some years, and it would be hard for me to navigate through healthcare. And why would we expect somebody who knows nothing about healthcare and is not engaged to be able to make decisions about their healthcare? I think we really need to support people and educate them on that process.
Which is a nice shift in mindset from make the decisions all on your own to help me understand your values so I can help you make the decisions that are right for you.
Absolutely.
Yeah.
Said it well.
And that actually fits in really nicely. There's another question. It's amazing how these providers give patients the power to improve their health care. What happens when the patient doesn't have access to the resources to improve their lifestyle, eating habits, et cetera? Do you connect them to the appropriate resources?
We try, but again, we do it really specific to their organizations, and we try to look at what is the challenge that we have with our population. I was describing earlier in a conversation where we had truck drivers who we know when they come in and get their sheets, they go on the road and most of the time all they can have access to is fast food. It's really where you're going to find really healthy food, and if you do, it's probably more expensive. But what we did find is when we pick up the sheets, if they had a refrigerator there that had cut up vegetables and cut up fruits, that they'd actually take it. We found that you put good stuff out there, people are still going to take it. It's free. So they, so we start to look at how do we integrate the right choices into their workflow so that we can actually have a bigger impact on it. And we found we have some organizations where stress is the number one cause of concern. And the last thing you want to do is put a program or a situation on stress and stress people out even more. But what you want to do is you want to put maybe healthy messages out there, like sleep is important. Think about this. Not stressing them to think about stuff, but actually putting information out there that actually guides people to the right situations. But I would say another thing that's important is who has big influence on their population is the employer and the primary care, and you put them together to think about how do we solve problems. You're going to get some really good solutions come out of that process. So the employer can lead, they can set up a culture, they can set up ideas about, the other thing we measure is we measure unique participation, because we can measure visits, but it's really about how much are we penetrating the population. So we really try to get at least 85% unique participation of the employee membership in the first year. But what that does is allows the employer to say, wow, we should really focus on, quit smoking, because we got a lot of people who are doing that. Let's figure out how to do that effectively. Or, wow, we really should work on these sorts of things as education. So we now are able to give the tools to the employer organization working collaboratively with their primary care provider to identify how do we take on some problems that we see we have that we can actually help people get healthier.
That's great. So changing gears a little bit, the next question from the audience is about being a woman in healthcare. So you said you grew up in a family that didn't believe girls should go to college. You've worked in many high-profile leadership positions, mostly surrounded by men. So what does the evolution of women in the workplace look like over the course of your career? That's quite a transition from over the course of your life.
So I always try to first believe that when you're all professional, you're all professional. It doesn't matter who you are, what you look like, and where you come from. But there is an evolution, I think, from the female force going on. And again, I've been around for a long time, but I think I went through that phase of where women in the workforce we were almost competitive to each other. It's like, oh, there's two of us now. Should we really mentor each other? It's like, because it was hard enough for us to get where we are without having other people want to come in and be competitive. And then you go to, well, it's okay. So now you're the female in the boardroom, and yes, there is still man speak. And for those of you who don't know it, it's when a woman will be in a room and they say something and the man repeats. I could say something really brilliant and have a man say it, and it's really much more important when it comes from that person. So you kind of get used to a lot of those things. But I would say we have reached a point where we're everybody's pretty much equal and appreciated and respected. But it's been an evolution, because when I started, there weren't a lot of people going in, and there weren't a lot of risk takers. I don't know if women were necessarily supported to be risk takers. But you end up now trying to train people to be equal and to be able to take risks, and that was not necessarily when I started my career.
Yeah. Working on the HR side, what was your experience in hiring?
Well, I think I was fascinated when I didn't last in HR that long, but I was fascinated when I would be interviewing people for jobs, and what I would see is a young man come in and say, I can do this job, and he had no experience, but he was determined he was going to do this job. And I'd see a woman that would come in with all these years of history that waited to build up her career to get to that job. And so it was just, you just found that you just had people who approached the risks differently, because that's the way they made their accomplishments. They did this, we'll do this, and then we'll be able to be qualified for that. Where you'd see that the men were a lot more risk takers. They were trained to go out and they're going to make a living. They're going to do that, and that's kind of the era when it first started. And I think we're seeing a lot more women in the workforce now who are taking risks, who are starting their own companies, who are doing things, and showing that it doesn't matter. We can all survive if we do the right things.
Yeah. Well, we have great role models to look up to. So with your parents, growing up in a community that didn't necessarily look to medicine and healthcare as a place to get that advice, how did they feel about your career in in this space, and your impressive rise to running really large organizations and starting companies.
So my father, they were farmers, they didn't really have a long lifespan, but my father on his last few days of his life said to me, prior to this, my mother, who had died earlier, looked at me one time and said, "Why didn't you become a lawyer?" And I thought, why don't you not say that? That's a little offensive now. But anyway, but my dad, on his last few days, he looked at me and said, I just want to say you must have put in a lot of hours and overtime as a secretary to be able to take care of us like this for the last 30 years. And I said, I did put in a lot of hours, yes. So he never really accepted the transition.
There's so many questions there and so little time. So the upvoted one now, I think something I really, sorry about that, admire is the conviction that you've shown throughout your career, even from hitching a ride to DC to find what's out in the world, to standing by patients every step along the way. There's a medical student writing who says they want to make an impact in healthcare through improved access. So what advice do you have to them to carry a similar conviction to how can they be more mindful as providers, and how can they really go about driving change?
I think people, first of all, I think you always have to be an honest person. Be honest with yourself and be honest with the people you serve. I think we aren't playing a role; we're playing reality, and so I think you determine who you are and where you best fit that role. And then you're honest with your patients and with your customers. The customers know me pretty well, and they know what I'm going to say. I'm very direct and honest with them about how I believe. But they know I'm passionate. And the thing that I think we get away from these days is that if you live up to your word, you're almost an interesting person. It's like really. If I make a promise to somebody, or if I say I'm going to do something, I'm going to do it. But I think that's shocking to people sometimes. I think people say things because it sounds good, or it works, or it's convenient, or I don't want to hear you talking anymore, or this is what happens. But I always try to say and they know that I would, if they didn't hear from me, if I promised them something and they didn't hear from me, they probably want to call and see if I'm alive or not. Because it's really important, and you build your credibility by really living up to your word. So I think you have to have all of those in order to be successful. And trust me, I never in my life ever had a plan, number one, but I never expected to be a CEO or running a company, or, when I first got into it, I was thinking to myself when we first started this, it's so much easier to spend somebody else's money, but in being a CEO of another company. But now that I'm on my own, it's like, well, this is, okay. But you really have to make a difference, and you have to believe in what you're doing and do it well, and not deviate from that. I see a lot of people who will do startups, and they don't think it through all the way to the end. They're not. They have an idea, but they don't have the experience. They don't. They try to make money come faster by getting deviated and waver from their mission. You have to have a conviction of what you're going to accomplish, and you can't deviate. My business partner would always come to me and say, "Hey, what if we do this?" And I go, "No, I'm doing it." Hey, what if we do this? I'm not going to do that either. We do this well. We do it really well. That doesn't mean we can't improve. I also say as well, if we're doing the same thing this year that we did last year, we're doing all the wrong things. We have to keep improving, but you have to be able to prove the conviction that you have to get the results.
I think that connects to the next question is, what are some of the unexpected challenges you faced in building a company and going from leading a large health system to the startup space?
Well, the first thing that was shocking to me was that I went from running a company and being a CEO and part of the CEO group to being a vendor where they could kick me to the curb whenever they felt like it. And I was like, well, that doesn't feel, I'm not used to that. So it was sort of like, oh, I am a choice or not. Like now I had to compete for attention and be able to, which was very interesting to me. And I also learned to be able to work inside people's organizations. All culture is extremely important to getting things accomplished. And my business partner would always like, we're driving to do this. I'd be always like, we're actually sitting at somebody else's house. You don't go in and arrange their furniture. You have to sit and listen to their culture, and you have to understand that. So it was really interesting to go from running something to being a vendor, and then really to having to shape a solution, not necessarily come with a solution, but you have to create a solution, and you have to understand the other person, even though sometimes you sit there and you go, yeah, I wouldn't really do stuff this way, but and you see some of the dysfunction going on in the organization, and you go, I don't know about this organization, what's going on, but I used to say to my business partner, now that I've been doing this for 5 or 6 years, this was early on, I think I could go back and be a much better CEO because I can really see the gaps and problems and issues where people don't address issues, they don't take care of it, they don't face into their cultures, they don't do a lot of things. And the other thing I realized is that if you have a dysfunctional team, the first thing they do is blame their vendor. so I was like, okay, that sometimes is me, but but it was very eye-opening. But I also would say if you're not humble, it's not for the faint of heart, because if you're going to start a new organization, you really need to be humble about making mistakes, learning, continuing to grow, pick yourself up, and continuing down that road.
Do you ever think you'd go back to the health system side?
Yeah.
Yeah. Okay.
I would.
It's
maybe.
good for all vendors. I think having that empathy and having had the experience wearing both hats.
I think the challenge for any established organization is that the culture is there. And so you really have to figure out how do you, again, meld into that culture to be able to drive change. But it's a challenge.
So we only have a couple more minutes. I don't know where this hour went. Thank you so much for joining us. My last question for you is, what makes you hopeful for the future of healthcare? Like, what do you see in 20 years if we're doing it right? If models like Activate scale, what does that look like?
So one of the things that was always interesting to me is I would sit and talk with my friends in Boston and say, gee, if we did healthcare right, think of all the people who would be out of work. Because I thought, well, we're providing a whole lot of healthcare to a small group of people. But what I realize now is that that was a pretty naive thought, because there is roughly half of the population that's not engaged in healthcare. So we're not necessarily engaging all of the population that really needs the healthcare, needs it when they need it, getting the age-specific screenings, getting the proactive care. There is plenty of opportunity to improve all of the healthcare. I hope we don't forget that we have a large population and large needs of a lot of people that aren't there right now. And so I get concerned about looking at systems to be created without thinking about how we're managing the cost and improving the health. Because I don't know if people actually understand you really do have to put the patient back in the center, or you're not going to be able to change and have a system that's going to work. You can design systems all day long, but you cannot change that person without getting them engaged.
Well, here. Thank you so much for joining us tonight. Please join me in thanking Deb for her time tonight.